Hi, I'm Kelly Collins. I'm here at Abington Memorial Hospital in the Department of Gynecology and Obstetrics, and I'm joined by Dr. Stephen Somkuti. Could you please introduce yourself with your full title?
Sure. So I am a attending physician in the Department of Obstetrics and Gynecology here at Abington, and the Division Director of Reproductive Endocrinology and Infertility, and the Director of the Toll Center for Reproductive Sciences in Vitro Fertilization Laboratory, and I'm a full professor in obstetrics and gynecology through Temple University School of Medicine.
Okay. So what kind of hope are you offering currently for couples and families trying to conceive a child?
Well, this program was started by Dr. Schinfeld, my partner, in the late 80s, and since then we have had thousands of babies born through in vitro fertilization, as well as techniques that we use in the office. Our goal is to help everybody try to start a family. The typical folks that we see are, if you're under 35 years old, if you've been trying for a year without any success, that pretty much defines infertility. If you're 35 to 40 years old and you've been trying for 6 months, then you should come see a fertility specialist. And if you're 40 and older, basically you should go straight to the fertility doctor and kind of don't pass go and get an evaluation.
Maybe you already answered this, when is the best time for a couple to come into your office and have a meeting?
Well, essentially, people can come at any time if they want to be educated. So we also do pre-pregnancy counseling, and we have folks who are concerned about previous exposures in their past to sexually transmitted diseases, or they've had ruptured appendix, or infections, or surgeries, or miscarriages. Or they're just wanting to know whether they have the capacity to reproduce. So there are some quick, simple, easy, and simple tests that we can do to evaluate the reproductive system on both sides of the equations to give people some reassurances that things are okay, or alternatively identify issues and then offer some solutions to those problems.
So you mentioned that usually people come to you with pre-existing conditions. With or without those being present, what type of risks are involved with getting started with in vitro first, and then if you need to go further down the road for more treatment? Is it a guaranteed every time? You said there's been a lot of babies born through in vitro in the past 20 or so years. So a regular couple entering a program, like what kind of risks would be involved for them?
So first of all, if we talk about the efficiency of human reproduction, if you're under 35 years old and there's no problem between two people just noodling around having intercourse, the chances of getting pregnant is 20% per month. That is an immutable fact in nature. We're not dogs, we're not sheep, we're not cows, even though the friends and relatives may act like animals. You know, you don't go into heat once a year and bang, you're pregnant with 90% efficiency. Humans are fairly inefficient when it comes to reproduction. Throw in a problem and that 20% starts to head in the southward direction. By the time a woman is 40 years old, that 20% has dropped to 12%, and by the time you're 45, it drops to 1%, and that's just from the aging process alone. So you want to do things in a systematic and stepwise and logical fashion to evaluate the reproductive system and then give people options for treatments. The risks that are encountered with fertility therapies can involve not only physical, but also psychological and emotional, as well as financial, because this can take a big toll on couples' relationships, or even single folks who are attempting to try to get pregnant using donor gametes. So we try to treat the patient or the couple as a unit and give them and empower them with information to help them make intelligent decisions about their care. And there are counselors who themselves have been through fertility problems, who are available to help people get through those rough emotional spots, if you will. Some of the medical risks that are involved in taking fertility medications. There's certainly the minivan syndrome, where you're increasing the chances of multiple pregnancies when you're taking fertility medication, because many of our strategies involve putting more targets in front of the darts, if you will, and getting the darts closer to the targets.
Sure.
So just putting the sperm and the eggs closer together. And when you're using fertility medications, we rely on typically producing more than one egg, which will increase that chances of having multiples. And obviously our goal is only one healthy child, but those are one of the bigger risks that you can encounter. Other things include a pregnancy gets stuck in the fallopian tube. Very rare, but a few percentage of the times you have an ectopic pregnancy. There's also miscarriages, because there's no guarantee that there's a healthy outcome. And there's also risks of the medications themselves overstimulating the patient. They're also taking sometimes injections, which you can feel like a human pincushion. But again, the staff is designed to try to get people through this through education and emotional support.
Can you talk about the program here at Abington called autologous endometrial co-culture? Did I say that correctly?
Yes, you did.
Okay,
So
great.
my partner, Dr. Larry Barmat, developed a technique for people who have had multiple failures in vitro fertilization. Now remember, in vitro fertilization, the word in vitro is Latin for in a glass dish, if you will. So it was designed for women who had originally blocked fallopian tubes, because the sperm and egg meet at the end of the fallopian tube.
Sure.
So if I show this model to you, the sperm and egg meet at the end of the fallopian tube here as the sperm swim up to the end of the tube here. But if your fallopian tube is blocked and damaged, then clearly egg can't get into the tube to serve as a target for the sperm swimming up through the tubes. So in vitro fertilization was originally designed as a tubal bypass procedure, if you will, where you put the eggs and sperm in a dish, in vitro, create the embryos, and then place the embryos back up into the uterus, so you don't need your fallopian tubes. Since then, there's numerous other reasons for why we do in vitro fertilization: low sperm counts, hormone disorders like polycystic ovary syndrome, where women are not ovulating on a regular basis, endometriosis, uterine fibroids, recurrent miscarriages, advanced maternal age. The autologous endometrial co-culture technique, developed by my partner Dr. Barmat when he was up at Cornell University, was for folks who've been through multiple cycles of IVF and have poor embryo quality. And that can mean fragmentation of the cells in the embryo, or they've also had multiple failed cycles. And what happens is it's the premise that mom knows best. So normally embryos are grown in a Kool-Aid of salt water and vitamins and growth factors. What this technique does is take a sample of mom's cells from inside the uterus, and we grow them in a dish, and then you put the embryos on top of those cells. So now from day 0 until they go back into the mom, which is typically 3 to 5 days later, the embryos are being exposed to all the vitamins and growth factors and nutrients that mom's endometrial or uterine environment would normally be exposed to, that we cannot replicate in a dish. So this technique, which is only done in a few places on the planet, is something that has given new hope to folks who've had multiple failed cycles and poor embryo quality and fragmentation, because it seems to improve the quality of the embryos through the use of this exposure early on.
You've mentioned that it's really only being practiced in a few places in the whole world. So why Abington? Why did you guys decide to bring that?
Well, Dr. Barmat brought that technique with him from Cornell, and it's a very finicky technique. So it's not easy to grow those cells in a dish. And I tried when I was down in North Carolina at Chapel Hill and Duke for years to try to get them to grow. And they must have left a couple of key steps out of their papers because, we just didn't have any success. And so he was able to bring that technique to us, and we're able to establish it here. We've had people come from all over the world to learn that technique here. We've had people from Israel, from Taiwan, from Turkey, from France, from South America come to learn that technique. So, but it's not easy to do.
So another point that I want to point out that makes your program here special at Abington is your connection with the LBGT community. What kind of success have you had in that direction, and also why do you feel like that is an important part of your program?
So we've always been non-discriminatory to any person who wants to start a family. I mean, our goal is to help you achieve your goal, irrespective of what your orientation is or your ethnic, religious, any type of background. So we just don't discriminate, and everybody's treated with the same respect. And as they taught me in medical school, treat every patient like your father, mother, sister, and brother, and you will never go wrong. So we're very successful in both single ladies as well as gay and lesbian couples in helping them achieve families. We reached 600 folks at the wedding expo, and we had a great turnout. And it's wonderful to be able to help folks start families.
Absolutely. Why do you feel, in general, in terms of serving everybody, that Abington is really the best place to get this type of care?
So I can tell you from a personal perspective, having been a fertility patient myself in the past, that there's no substitute for experience sitting on the other side of the table, because you cannot explain the frustration, the depression, the anger, the fear, the nagging mother-in-laws, the pregnant sisters, the pregnant dogs, the pregnant best friends, the crying. And, not that everybody goes through that, but there's just really no substitute for that. We have designed the office to be as user-friendly as possible and provide people with the support and the care that, again, all of our family members would be accorded. So I tell every single patient that there's no question ever that is too silly or too stupid or too dumb. The phone is your friend, and there aren't many physicians anymore these days who tell you, please call. So we've made ourselves very available. I mean, this is not going to your family doctor for a sore throat or an earache.
Right.
It's obviously a tad more intimate than that. So we've tried to handpick everybody in the office to try to reflect that similar practice philosophy.
Great. Well, thank you so much for talking with us today and for exposing this great service that you guys have here at Abington.
Oh, you're very welcome.